Hi everyone, this is Martin Kanne, endourologist from Berlin, Germany, presenting a HoLEP surgery here, an block enucleation early apical release hybrid power technique. I'm going to explain it a little more detailed while we're going through the surgery. So here you see the endoscopic view of the adenoma. We see a very prominent verumontanum, and then I am going to show you how I am marking the early apical release cut. I will perform first, of course, in the bladder we are going to check the urethral orifices, and I checked the bladder wall for the absence of a bladder tumor before. So now I'm starting to use 60 watts, in this case 1.5 joules and 40 hertz homeostatic energy to do the apical release cut, just cutting the mucosa here and releasing the inserting fibers of the sphincter to create this white line. Is the first step of the procedure. I'm marking all around. As I said, I'm using a hybrid power technique, so this means in the apical part I am using the blue pedal, which is 60 watts, as I said, 1.5 joules, 40 hertz. And as I move on, I will switch to the high power setup, which is 3 joules and 40 hertz. And will indicate to you when this is happening. So now you see we already completed the white line here. And next step is to move on, deepen a little bit. This is the difficult part up here at 12 o'clock position. And now we are going to look for the layer and start enucleating. We have the sphincter preserved here, and now we're switching to 120 watts, 3 joules, 40 hertz, taking the laser fiber a little bit closer, and then we're starting to enucleate to find the layer here between adenoma and the capsule. And now you see that I have much more burst effect of the bubble, which is formed at the tip of the fiber with a 3 joule setup than it is with a 1.5 joule setup. So what I'm doing now is to look for the plane and to advance and go further a little more. I'm doing the same on the right side here. This is going to be an en bloc surgery, en bloc enucleation, as I said. It's a medium-sized prostate, 60 grams, and it's just an everyday case, a regular case. You see, it's not the best plane you can have, not the best layer, but it's an everyday case, as I said. Wanted to show you not just the great surgeries we have, of course, often, but just a regular case as we experience it in our hospital, which is located in the eastern part of Berlin. So now I did the incision in front of the verumontanum, and now I am moving on to do the enucleation below first. Now you see this is the release cut is much more open now, and this is where we want to go now and work in the angle. So this is the angle I'm going to work on now. So you always have to be careful when you pull your scope back and don't want to get out of your release cut. So you always try to go in the layer and then pull back and release it all the way around and up to 12 o'clock. As you see, I turned the instrument. It's now upside down, and the fiber is coming out. at the 12 o'clock position. You see here, this is my release cut, and I have to work on just underneath the release cut to find the layer here, which is then leading me to the 12 o'clock position to release it completely all around. This is the difficult part of the surgery, no doubt. We'll do the same thing on the other side. This is the layer here, you see. So I do the same thing. I enter the layer and I advance up. I do the enucleation towards 12 o'clock. Always go back and check where my apical release cut goes. So I undermine it here once more. This is, by the way, of course, this is as I'm working apically, I am using 60 watts again. So I switched to the blue pedal with 1.5 joules, 40 hertz. So this is the idea of a hybrid power technique using low power setups in the apical part. And once you are done with the release of the apex, then I move on with more power and with more speed in the morcellation. So there you see the release cut is quite okay. There is no injury of the mucosa of the sphincter fibers that are inserting into the adenoma. So I need to work a little bit my way up. So I have it all around, and I can move on in the plane. So now I will change my setting to 3 joule 40 hertz on 150 joules, and you see the fiber is moving a little bit more just because of the power which is increased, and I'm having the feeling that I can do a lot faster enucleation. You see there's almost no medium lobe, so this is no cutting of the video. The video is in original length, original speed. I just made a little pause of a second to show you the differences of the power setups. So this is 120 watts now, and I'm moving on and pulling. Always pull your scope back and move upwards to create the round enucleation layer all around the adenoma. So here I am, 12 o'clock position, and I'm trying to go over to the other side. This is the right side here. Sometimes you leave some little tissue up there, which is not a problem to do it right now. You can always do a tissue trimming, and I think I will do a little tissue trimming at the end. So you will see it's very easy to get rid if you have the feeling that that tissue that you leave out there is maybe relevant for the urination, which is most of the time it's not relevant, but if you want to make it look a little smoother, then you can do a tissue trimming there. So I'm quite around here. So I move over to the other side. So this is below 6 o'clock position. Sometimes I do turn my instrument again, and I look for the layer, because there was sort of 2 layers. You always have to be sure that you are in the deepest layer, which is closest to the capsule, to do a complete enucleation. We don't want to leave a lot of tissue inside. So by advancing here, you see how the tissue, how the layer is opening. Of course, we're doing a no-touch technique. The bursting of the bubble from the laser fiber is doing the work. We're not pushing the adenoma by force. We're just moving the instrument and doing a no-touch technique to find the layer. Okay, so we're moving on here. And this is really the time for 120 watts to move on faster. You see there's a little bleeder there. It's not the best layer you can find in a prostate. It's an obese patient, 75-year-old patient with comorbidities, aspirin, taking aspirin. See, there's always, when you're close to the capsule, you see the big vessels there, and you need to, when you're there, do the coagulation. By the way, I don't switch to the blue paddle just for doing the coagulation. I think that is a coagulation is possible with the yellow, with the 120 watts also, same way. You just need to modify your distance to the vessel a little bit. So here I am, and it's sometimes I have the feeling that the adenoma, most adenomas are a little sticky down at the 8 or the 5 o'clock position. In this case, it's okay. So if you're interested in our hospital, we are a relatively small hospital in the eastern part of Berlin, as I said, but we're having a strongly growing urological department there with a special focus on BPH therapy, on enucleation procedures. We have been increasing our numbers of surgeries quite a lot in the last years. So this year we will be doing more than 500 cases of HoLEP. We will be doing some cases of resume therapy, which is an alternative for patients who wanting to preserve anterograde ejaculation, or for patients that are just not fit to receive a HoLEP, or patients that are willing to give it a try first to do a resume therapy and see how it helps them, and then maybe come back to a HoLEP in a couple of years later. So here you see that in this part up here, the 11 o'clock position, there is some material, some adenoma, which is still there. So I have to move back my scope and try to find the layer around it. So I go up the lateral part here, and I check again, and if it's stuck a little bit, as I said before, 8 o'clock position is sometimes a little difficult to find the layer and to get the adenoma out of the layer there. And then you move all the way up, and then you can you eventually fall into the layer of the other side. And here I have the feeling that I will look again from the other side, always checking the apex, checking the sphincter, which still looks good. So I'm definitely confident that we did everything we could to preserve the sphincter fibers, and I'm quite advanced here in this part. But still, I want to complete my nucleation to the other side, and I have the feeling that I'm not quite there at the same level, so I'm going from the other side, and I think I know I did it. Now I am here. Yes, now I have it, connection, which is good. Now I have to do a little tissue trimming here, as you see. There is some material which is in my way now, but there I have a good layer there, and I'm trying to create this layer for the whole adenoma. So the next thing now, what you can do now is do an en bloc technique. So I do usually I try to, if I feel comfortable up here, I'm trying to go into the bladder at the 12 o'clock position. I'm looking for the bladder here. If I don't, if I have the feeling that I'm not quite sure if I'm in the right plane, or if it's a very high adenoma, or if it's uncomfortable for some reason, then I advise you to look for the original prosthetic urethra and then just do an incision at the bladder neck at the 12 o'clock position from the prosthetic urethra, and then you always find the bladder neck and the bladder cavity safely. And if you have fear of ending up somewhere you don't want to end up, then do the 12 o'clock incision. In this case, I don't think I have no doubts that I am in the good plane up at the 12 o'clock position, so I will be doing it on block classically with finding my bladder at the 12 o'clock position. So this is now working at the 6 o'clock position. See, the fiber is getting, using the fiber, it gets shorter and shorter, and you should then push it. See, I do it here. You should push out the fiber a little more to get closer to the tissue. Still, of course, you see it's a no-touch technique. We don't have any putting our fiber into the tissue and then shooting. You never do that. Never push the fiber somewhere you don't see the tip and then shoot, because you don't know where you're going. So here I have the feeling that I'm getting closer and closer to the bladder neck. So I'm sticking to the very 12 o'clock. See, the layer is good here, and it should be close to the bladder neck, which is just a matter of seconds where you feel it. You feel that your instrument is going down. You're on the way back down, so there you see the bladder. Okay, so now go back and do the enucleation in the plane, ending up at the bladder laterally, coming from down to up until you see the bladder. Yes, like this. And now I think it's good to turn the instrument again and then just slide down here the bladder neck very naturally. You just move forth and back, and you don't push. It falls into the plane here. It literally falls into the plane. Trying to do the same thing at the other side. So I'm here below. Looks like I have two planes again. One is this and the other one is down. So we'll check later which one is better. It's not a big difference. Okay, so I already decided that I'm going for this plane there, because it's the right one. And now I am moving up from the other side. I think I will turn my instrument again. No, I'm doing it now like this. Now I'm turning my instrument again, as I said. And I'm going up, and I see there is the bladder. So just to get to the bladder, now turn the instrument and slide down smoothly. No pushing. It's by moving forth and back. It's leading you into the right plane. So go below 6 o'clock, then you see that it's still attached at the 6 o'clock position. You push it up a little more, and and you see the plane, and it's only detaching now the final part of the adenoma. You see verumontanum is here. One more time, we should go back and see if everything is fine. So this is a nice sphincter view here, I think. Do a little coagulation. Always when you see a bleeder, don't forget to do the coagulation right away. You see there's a little tissue which is still stuck somewhere here. I will take care of that later. And now trying to release the last part of the adenoma by pushing it to the bladder neck a little bit, checking all around, looking good here. Nothing, no bridges. So it's going to be the final detachment at the 6 o'clock position. It's like doing a medium lobe enucleation, as we did in the days when we were doing 3-lobe technique. So there you see, I have to be careful there to not go too deep. So looking good here. Finding the bladder. This is probably the only part of the surgery where you are allowed to touch the tissue, is to release it from the bladder neck. Getting closer here, and there you can sort of cut it out from the bladder neck. Going to check for the urethral orifice in a bit. See here, this is the last part. So now it's all enucleated, and you can push it into the bladder. Looking now as the fossa is now free of the adenoma, you can see better and look for bleeders. This is the remaining tissue. Now I'm going to do the tissue trimming, as I said before, as it's still stuck at some part here. It's just to make it look a little nicer there. So this is now the tissue trimming ended. Okay, so this looks good. This is the adenoma inside the bladder there. One piece on block enucleation. There's a little bit of tissue there. Checking one more time for the sphincter. Satisfied with that. See the verumontanum there, doing a little coagulation. And now check inside for the urethral orifice, which is there, and the other one is there. So no problem. Now changing for morcellation. So now I have a machine where the morcellator is integrated. So I have only just 1-2 touches on the display to change to morcellator mode. And I change my optics to the morcellator optic. And I have the knives and I put them in, and I am within 30 seconds or so, I am ready to go, which is a huge advantage of the laser machine. I think it's very comfortable. I don't have to change my switches. I have the same pedals. I have only 2 pushes on the screen, and then I am ready to do the enucleation. As you see, I'm already doing suction on the tissue, and I'm taking it to the fossa. And now I do, in the fossa, I do the morcellation. So you can take your time now and see how fast I am with the morcellation. As I have the tissue in the fossa, it's not escaping, it's not really going into the bladder. So I think it's very safe to do the morcellation in the fossa and not do the morcellation in the bladder, because in the fossa you cannot morcellate any bladder wall. During the morcellation, the vision gets better. At the beginning it's not so good here, but it will be getting better and better as the bladder is constantly full. So I'm not losing the tissue here, as you see, and it was morcellated tissue was 43 grams. So, and I think it took a little more than 2 minutes to do the morcellation of the 43 grams. Morcellation is a very important part of the surgery. You see here, my vision gets a little foggy, so I think I will be doing a cleaning now of my camera, as it gets a little bit foggy here. It's quite foggy. So now I will take off. And do a little cleaning. Oh, looking better now. Okay, going back and still have my tissue attached to the opening of the knife, and the last parts of the adenoma are being morcellated. So this is like a beach ball, which is the last part. So that was it. So I'm looking now here in the fossa if there's something still inside. I'm looking to the bladder. I'm doing suction, seeing if anything is still there. So what I do now is I change back. I always do a final coagulation after emptying the bladder. Now the bladder, as I'm changing optic and light cable again to the laser, I'm letting the bladder get empty, and then you see some of the bleeders, and I am switching back to the laser mode now. Check again for the urethral orifices 1 and 2. So now I'm going to do the final coagulation. I have the experience that it's usually wise to do a coagulation in the bladder neck and around the verum. Sometimes also up at the very apical release part. So I hope I will be doing a coagulation of the bladder neck now. Otherwise I am not telling the truth here. You see a little bit of tissue here still on the capsule. No real bleeders, but a little bit of bloody areas, which I will be just coagulating. And now I'm just looking at least I'm looking at the bladder neck, and it looks very good. There's no irrigation now, so I don't have to do a lot on the bladder neck here. So now I'm fine. Doing it around, a little bit of coagulation around the verum. You see it's a little bloody here. So now I'm checking again. Bladder neck is okay, nothing left inside. I am emptying the bladder one more, one more time to get a look at the sphincter, which is here, which is closing perfectly. So I think this is really nice, and I'm satisfied, and I leave. So that was it.